Hello, my name is Morgan Culver, and I'm a clinical pharmacy specialist at VCU Medical Center in the area of hematology and oncology. And today I'll be talking about supportive care 1 topics, including chemotherapy-induced nausea and vomiting, chemotherapy-induced diarrhea, mucositis, anticoagulation, pain management, and palliative care. I have nothing to disclose. We have several learning objectives to discuss through this module, focusing on choosing individualized therapeutic plans for patients with GI complications, including nausea, vomiting, diarrhea, mucositis, anticoagulation, pain, and palliative care in patients with cancer. We'll also cover materials that deal with medications used in the supportive care setting and select appropriate therapeutic interventions for the management of pain and other symptoms that require palliative care. Finally, we'll identify some of the current literature and guideline recommendations used for the management of complications for cancer and cancer-based therapies. We'll start with covering chemotherapy-induced nausea and vomiting. But before we discuss this complication in more detail, I think it's important to differentiate the 2 symptoms of nausea and vomiting. This is one of the most common fears that patients receiving chemotherapy can face, and so it is important to be able to differentiate both of these symptoms for them. Nausea, which is mediated by the autonomic nervous system, is defined as a sensation that's accompanying the urge to vomit but does not always lead to vomiting. Compared to vomiting, which is due to stimulation of reflexes coordinated by the vomiting center, which results in forcible, voluntary, or involuntary emptying of the stomach contents through the mouth. The acute vomiting after chemotherapy is due to neurotransmitter release from cells that are susceptible to the presence of a variety of toxic substances in the blood or CSF. So ultimately, the brain is identifying chemotherapy as one of these toxic substances. As a result, multiple neurotransmitters are released, including serotonin, histamine, and dopamine. And because of these multiple pathways, the emetogenicity of chemotherapy agents can vary. And we'll go into this in a little bit more detail. But first, let's discuss the various types of chemotherapy-induced nausea and vomiting, because these are prevented and managed in different ways. Acute nausea and vomiting typically occurs within the first few hours of administration, can peak within several hours, but ultimately resolves within the first 24 hours of receiving chemotherapy. This is compared to delayed or late nausea and vomiting that occurs after that 24-hour mark, can peak within 2 to 3 days, but can last up to a week. This is often seen in patients getting higher doses of chemotherapy, patients who get more than 2 consecutive days of a medication, and it's more likely to occur in those patients who have had acute nausea and vomiting. During both the acute and delayed phases, the patient can experience breakthrough nausea and vomiting, which is defined as nausea and vomiting that occurs despite proper preventative therapy. A different type of chemotherapy-induced nausea and vomiting is anticipatory, which actually occurs before the patient has received the chemotherapy. This is due to a conditioned response to a stimuli, such as a smell or a sound. This would occur in a patient who's received several chemotherapy infusions, and a previously neutral stimuli, such as the beeping of a chemotherapy pump, could condition the patient to have a response such as emesis. So if your patient comes into clinic, they're used to a routine, they hear the pump beeping, they get home, they experience nausea and vomiting. After that series of events occurs several times, ultimately they're conditioned to associate that pump beeping with a nausea episode or a vomiting episode where the pump itself can trigger that event. This usually occurs after 3 to 4 prior chemotherapy treatments, and the probability of it can increase with the number of infusions. The severity of it will increase closer to the time that the chemotherapy is being infused. While chemotherapy agents are most often implicated in nausea and vomiting in the cancer patient, there are various other potential causes of nausea and vomiting that must be fully evaluated. These include tumor invasion into the GI tract or the CNS, such as in those patients with brain metastases, of course, therapy-related issues, but other GI issues such as constipation, gastroparesis, or reflux can commonly cause nausea and vomiting in cancer patients. There are neurologic and metabolic issues, including fluid and electrolyte abnormalities, and non-chemotherapy agents such as opioid and antibiotics can also cause nausea and vomiting in this patient population. Infection and sepsis can be a cause as well, in addition to other psychophysiologic conditions, such as the pretreatment expectations of nausea and vomiting, which can escalate anxiety during chemotherapy. While these other causes should be adequately addressed, it's also important to assess a patient's risk for nausea and vomiting due to the chemotherapy specifically. And these factors are the same for both acute and delayed nausea and vomiting, but may differ slightly in the anticipatory setting. First, younger age can increase a patient's risk, as we see this predominantly in our pediatric population, but female gender can increase risk as well. Also, in patients with a history of morning sickness or motion sickness, patients who have received prior chemotherapy, particularly if they've had nausea and vomiting in the past or if their nausea and vomiting was severe or poorly controlled. The emetogenic potential of chemotherapy is certainly going to contribute to the patient's risk, and this can be dependent upon the agents themselves, the doses that are administered, the schedule, and the administration. We know that faster infusions of chemotherapy put patients at a higher risk of nausea and vomiting than prolonged infusions. And then finally, it's interesting to note that patients who have a history of chronic alcohol abuse are actually protected against a lot of the effects of chemotherapy-induced nausea and vomiting. I just mentioned that the emetogenicity of a chemotherapy agent or regimen can play a role in determining a patient's risk for chemotherapy-induced nausea and vomiting. But how is this actually assessed? Well, there are a variety of chemotherapy-induced nausea and vomiting guidelines available, and they attempt to categorize chemotherapy agents into categories based off of risk. This risk is determined based off of the incidence of acute emesis in the absence of appropriate antiemetics. So, for example, agents that are categorized as highly emetogenic means that there is an incidence of acute emesis in more than 90% of patients receiving that agent in the absence of prophylaxis. Once we've identified which patients are at risk for chemotherapy-induced nausea and vomiting, we start to consider which agents should be used to prevent it, starting with our serotonin receptor antagonists, such as ondansetron, granisetron, and palonosetron. These agents selectively block serotonin peripherally in the vagal nerve terminals, as well as centrally in our chemoreceptor trigger zone. They are effective in preventing acute nausea and vomiting, but are not very effective in preventing delayed. This is with the exception of our second-generation serotonin antagonist, palonosetron, which has been shown to be effective in the delayed setting. These agents have not been studied to be used on an as-needed basis. However, they are often prescribed that way. So it's important to keep in mind that their primary role is in scheduling them for prevention, not to use them as treatment for breakthrough nausea and vomiting. Overall, there are no differences in the safety or efficacy between the first-generation agents, which include ondansetron, dalasetron, and granisetron. And another important note here is that there is a threshold in terms of a maximum effective dose. Once the serotonin receptors have been saturated at higher doses of these agents, there is no increase in efficacy, so you will see dose caps for these agents. In terms of adverse events, headache, QT prolongation, constipation, and serotonin syndrome are all possible. However, serotonin syndrome is seen primarily when these agents are used in combination with other serotonergic agents. The next drug class that we have at our disposal are the neurokinin-1 receptor antagonists, or NK1-RAs. These agents inhibit substance P, or neurokinin-1 receptors, in the CNS. These are typically used in addition to a serotonin antagonist and dexamethasone for the prevention of acute as well as delayed chemotherapy-induced nausea and vomiting. However, they should not be used as monotherapy, as they've been found to be no more effective than placebo in this setting. Common side effects include fatigue, hiccups, weakness, and diarrhea. And then another important note about these agents is that there are significant drug-drug interactions, as they are substrates, inhibitors, inducers of CYP3A4, as well as inducers of CYP2C9. So pay careful attention to your drug interactions when these agents are being utilized. Corticosteroids, such as dexamethasone, are also commonly used to prevent chemotherapy-induced nausea and vomiting. While their mechanism is widely unknown, there are possible theories that include their effects on prostaglandin activity in the brain, antagonism of serotonin receptors, and a reduction in serotonin release from mononuclear cells. Corticosteroids such as dexamethasone are primarily effective in the prevention of acute and delayed nausea and vomiting, and they're mostly used in combination with other antiemetics. However, they can be used as monotherapy and are effective in this setting, particularly in lowly emetogenic risk regimens. Steroids are considered to be the cornerstone for successful prevention of delayed nausea and vomiting, and it's notable that there's no evidence of a dose-response relationship, particularly with dexamethasone. Dexamethasone is the preferred agent as it crosses the blood-brain barrier where it's thought to exhibit its primary effects. And then finally, for prevention of chemotherapy-induced nausea and vomiting, olanzapine has become a very popular option in this setting. It's an antagonist of multiple neurotransmitter pathways, including dopamine, serotonin, histamine, and acetylcholine. It should be used with a serotonin receptor antagonist and steroid and has a role in preventing both acute and delayed chemotherapy, nausea, and vomiting. To date, it's been primarily studied in our highly and moderately emetogenic chemotherapy regimens. Because it displays an effect on multiple neurotransmitters, it does have a wide adverse effect profile, including dose-dependent effects such as sedation and extrapyramidal symptoms, and other side effects as well, including increased appetite, weight gain, metabolic effects like altered glucose and lipids, anticholinergic effects such as constipation, QT prolongation, and sleep disturbances. Because of the warnings in the elderly population, if olanzapine is to be used, consider a lower dose such as 2.5 to 5 milligrams to avoid excessive sedation.
With a variety of antiemetic agents at our disposal, we need to consider how to best utilize them, and this is determined based off of a chemotherapy regimen's emetogenic potential. Let's look first at our highly emetic chemotherapy regimens. We have 3 sets of practice guidelines that currently make recommendations regarding antiemetic selection for prevention of chemotherapy-induced nausea and vomiting. These 3 are NCCN, ASCO, and ESMO, and all of them provide recommendations for the prevention of chemotherapy-induced nausea and vomiting in both the acute and delayed phases listed here in this table. Let's start with NCCN, which was updated in 2020. The biggest change in this update is that they did place preference to one antiemetic regimen over the others. Previous guidelines listed these 3 options, however, they were all seen to be equivalent at that time. However, with the new data that's come out regarding olanzapine, option 1 is now the preferred regimen. So we're looking at using olanzapine with an NK1 receptor antagonist, 5-HT3 receptor antagonist, and dexamethasone for prevention of acute nausea and vomiting in patients receiving highly emetogenic chemotherapy. These recommendations are consistent with those provided in ASCO in their 2020 update, where we're looking at an olanzapine-based regimen as well. Finally, our ESMO recommendations have not been updated since 2016, so they are a little bit more dated and not really as applicable to today's clinical practice, where they list olanzapine as an option to add to an NK1 receptor antagonist backbone. For our moderately emetic chemotherapy regimens, the recommendations are to primarily include a 5-HT3 receptor antagonist and dexamethasone, with the option of adding an NK1 receptor antagonist to those patients with additional risk factors or those who have previous failure. Despite the guidelines being updated in 2020 for both NCCN and ASCO, no major changes were made to the antiemetic recommendations for our moderately emetic chemotherapy regimens at that time. For our low emetic risk chemotherapy, either dexamethasone or a 5-HT3 receptor antagonist is appropriate as monotherapy, and this is true across all 3 of our guidelines, even in the 2020 updates. However, when we're looking at our oral chemotherapy agents, our NCCN recommendations are for a 5-HT3 receptor antagonist as an antiemetic for those medications that are moderately and highly emetogenic. ASCO did make some changes in their 2020 update where they moved from 4 categories to 2 categories of emetic risk, and this is to mimic the categorization utilized by NCCN. However, despite this change, their ultimate recommendations remain the same, which is to mimic whatever one would do for parenteral chemotherapy.
Managing those patients who experience chemotherapy-induced nausea and vomiting despite appropriate antiemetics can be a challenge. So it's important to keep a couple of considerations in mind. The first being that if a patient does break through despite appropriate prophylaxis, try adding an agent from a different class that has not yet been utilized. If it's effective, continue that as a scheduled agent until the patient's symptoms subside. If it's not effective, you can try to adjust the dose if you've not yet optimized it, or add an agent from a different class. It's always important to remember that for the patient's next chemotherapy cycle, their antiemetic prophylaxis should be escalated to the next risk level. A variety of agents can be utilized in the breakthrough setting, so let's discuss those in a little bit more detail. The first of which is metoclopramide. Metoclopramide is most effective against acute vomiting at higher doses. These higher doses block both dopamine and serotonin, so the dose does become important here. However, based off its mechanism of action, it will be important to avoid the use of other dopaminergic agents if metoclopramide is chosen. Other dopaminergic agents would include prochlorperazine and promethazine. These have been shown to be effective for breakthrough nausea and vomiting, especially after cisplatin use in the delayed setting. Adverse events with these agents include anticholinergic and extrapyramidal symptoms, as well as CNS symptoms such as sedation and confusion. And it's important to differentiate the difference in side effect profiles between prochlorperazine, which is more antidopaminergic, and you may see more extrapyramidal symptoms, compared to promethazine, which is more anticholinergic and would cause more sedation. Finally, haloperidol has been shown to be effective in the breakthrough setting, but the dosages for antiemetic use are much lower than those typically used for antipsychotic effects. However, the side effect profile would be similar, with QT prolongation, anticholinergic effects, and extrapyramidal symptoms all being possibilities. Other agents that may be utilized in specific situations include lorazepam, which can be used as an adjunct to prevent and treat anticipatory nausea and vomiting. Cannabinoids such as dronabinol have been shown to be effective in the breakthrough setting, particularly in patients who have not responded to other therapies. So this would not be your first choice for breakthrough nausea and vomiting, but may be used in more refractory patients. It's also been shown to be beneficial in patients who have concomitant pain or anorexia, and is ultimately reserved for patients who have previous experience with marijuana based off of its side effect profile and tolerability. Scopolamine patches have also been utilized for breakthrough nausea and vomiting, particularly in patients who claim to have motion-induced symptoms. Another potential GI toxicity following chemotherapy administration is chemotherapy-induced diarrhea. Up to 80% of patients receiving chemotherapy may experience diarrhea, with almost 50% of patients experiencing grade 3 or 4 symptoms. This can contribute to delays or discontinuation of therapy and possible dose reductions. A variety of agents have been associated with chemotherapy-induced diarrhea, and they're listed here for your reference, but it's important to note that targeted therapies are playing an increased role in these symptoms. In addition to the agent or regimen, there are numerous other risk factors for chemotherapy-induced diarrhea. These include advanced age, the administration and schedule of the chemotherapy agent itself, patients who are female, and those with a poor performance status. Other risk factors would include bowel inflammation or malabsorption or bowel malignancies, patients receiving their first cycle of chemotherapy, cycles with a duration more than 3 weeks, patients who have concurrent neutropenia or other GI symptoms. As I mentioned, the chemotherapy agent or regimen is increasingly important in determining a patient's risk for chemotherapy-induced diarrhea. While the incidence of grade 3 and 4 diarrhea varies based off of the agent, administration, and regimen, there are some more notorious agents, such as 5-FU, irinotecan, and one of our newer targeted therapies, neratinib, which actually there's a recommendation in the prescribing information to provide prophylaxis with the first 2 cycles of this agent, given the high incidence of grade 3 and 4 symptoms. The common terminology criteria for adverse events, or CTCAE, provide grading criteria for assessing the severity of diarrhea, which can be subsequently used to dictate management. As you're aware, grading ranks from grade 1 to grade 5 being death, And in the context of diarrhea, this grading is based off of the number of stools per day above baseline, as well as the symptoms' impacts on the patient's ability to perform their activities of daily living. For patients experiencing chemotherapy-induced diarrhea, there are two primary agents with data to support their use. These include loperamide and octreotide. Loperamide acts by inhibiting smooth muscle contraction of the intestine to ultimately reduce fecal incontinence, the frequency of stools, and stool weight. It has been shown to be more effective than diphenoxylate. However, its efficacy is limited in patients with more severe symptoms. Octreotide works by decreasing hormone secretion to extend intestinal transit time, decrease the secretion of fluid, and increase fluid and electrolyte absorption. It's primarily used second line, not because there's a lack of data or limited efficacy, but primarily because of cost. And it is notable that there is a dose-response relationship with octreotide in the setting of chemotherapy-induced diarrhea. In addition to CTCAE grading, categorizing patients as uncomplicated and complicated can drive therapy decisions. Uncomplicated cases are defined as those with grade 1 or 2 symptoms and no other complicating signs or symptoms, as compared to complicated patients that have grade 3 or 4 symptoms, or grade 1 or 2 with other associated symptoms such as cramping, fever, or dehydration. The management of these patients does vary based off of whether they're categorized as uncomplicated or complicated. So starting with our complicated patients, if these patients have grade 2 symptoms, chemotherapy should be held. At this point, we consider dietary modifications such as a brat diet containing bananas, rice, applesauce, or toast. We encourage oral hydration and provide loperamide at a dose of 4 milligrams, followed by 2 milligrams every 4 hours or after every episode of diarrhea. For patients who increase to a complicated categorization or who are diagnosed with complicated chemotherapy-induced diarrhea, these patients should have their chemotherapy held and be admitted to the hospital for appropriate management, including IV hydration and empiric antibiotics. These patients should receive octreotide at a dose of 100 to 150 micrograms subcutaneously, given 3 times a day or as a continuous IV infusion. If diarrhea persists for more than 12 to 24 hours after initial management, and they're still considered to be uncomplicated, at this point the loperamide should be scheduled every 2 hours. Empiric oral antibiotics should be started, and if patients have become refractory to loperamide, octreotide should be initiated. For patients who remain complicated or who escalate to complicated cases, infection should always be ruled out, and at this point you're considering agents used in a more refractory setting, such as deodorized tincture of opium. As mentioned previously, irinotecan is commonly associated with the development of chemotherapy-induced diarrhea. Irinotecan is converted in the liver to a metabolite called SN38, which is an active metabolite much more cytotoxic than the parent drug. It causes damage to gut mucosa during excretion, which ultimately leads to the diarrhea. SN38 is deactivated to SN38G. However, bacteria in the gut ultimately reactivate it back to its toxic form of SN38. Patients who are at the highest risk of developing irinotecan-induced diarrhea include those receiving weekly administration of the drug, those with a poor performance status or elevated serum creatinine, those who have a history of radiation to the abdomen or pelvis, patients with a low white blood cell count, advanced age, or syndromes that affect the liver's ability to metabolize and clear bilirubin. Irinotecan-associated diarrhea presents in 2 distinct phases, the first of which is the early phase that develops within 24 hours of chemotherapy administration. This is a dose-dependent presentation, ultimately resulting from a cholinergic response. The management is providing atropine at a maximum dose of 1.2 milligrams. After this 24-hour mark, patients are designated as having late irinotecan-associated diarrhea. This occurs at any dose or frequency, and the management is loperamide 4 milligrams, followed by 2 milligrams every 2 hours until the patient has gone 12 hours without a bowel movement. It's important to note here that the maximum dosing for loperamide in the prescribing information has been safely exceeded in the setting of irinotecan-induced diarrhea. The importance of supportive care should also be emphasized with these patients, including fluid and electrolyte management and encouraging a brat diet. The final GI toxicity that we're going to discuss is mucositis. Mucositis is relatively common, but the incidence varies widely based off of the offending therapy and the patient's primary malignancy. For both of these graphs, on the y-axis, you have the percent incidence of mucositis. For the graph on the left-hand side, the x-axis indicates the treatment that the patients received. You can see that the incidence can exceed 70% in those patients that have received total body irradiation as part of their bone marrow transplant prep. The graph on the right-hand side categorizes patients based off of their primary disease state. You can see that this toxicity is most common in patients with esophageal and head and neck cancers. The development of mucositis is very complex, starting with the first phase of initiation. In this phase, chemotherapy and/or radiation can cause direct toxicity to the cells, tissue, and vasculature, causing generation of oxidative stress and reactive oxygen species. There's also an increase in vascular permeability by the inflammatory mediators that allows for a local accumulation of toxic drugs. Next, upregulation occurs with a generation of messengers. 4 to 5 days after treatment, reactive oxygen species will damage the DNA, leading to epithelial cell death. The extent of damage to the tissues is based off of the rate of oral epithelium proliferation. At the same time, various genes are upregulated, which leads to the production of pro-inflammatory cytokines and expression of adhesion molecules. This ultimately results in tissue damage, activation of the COX-2 pathway, angiogenesis, and apoptosis. Next, signaling mediators are released after initial injury. This includes pro-inflammatory cytokines as part of a positive feedback loop. This can indirectly enhance and extend damage to the mucosa. While the biology has been altered in this phase, the tissue will still appear normal. Next is when patients become more symptomatic. Ulceration is the most symptomatic phase, and this peaks when blood counts typically reach their nadir about 7 days after treatment. Prior injury to basal epithelial cells will cause atrophy and mucosal breakdown. Oxidative stress will lead to inflammatory infiltrates, and bacterial cell wall materials can activate macrophages, further increasing the production of pro-inflammatory cytokines. Finally, the tissues begin to heal. When white blood cell count recovery occurs about 12 to 16 days after chemotherapy, epithelial cells will begin to proliferate and differentiate, and local flora will return. Due to the continued angiogenesis, patients are at risk of mucositis in the future. But how does this process ultimately correspond to the symptoms the patients may develop? As you can tell by this figure, patients will be mostly asymptomatic until about 7 days after the offending agent has been started. At this point, they may develop white patches, which may be mistaken for candidiasis. Following this, painful erosions and ulceration can occur. The severity of these symptoms can be graded using a variety of scales, such as those shown here, and the severity is graded based on the patient's ability to maintain their normal diet. There are a variety of risk factors predisposing patients to the development of mucositis. These include autoimmune disorders, diabetes, being female. Caucasian patients are at a greater risk than their African American counterparts. There's also known genetic predispositions to tissue damage, and folic and vitamin B12 deficiency can also increase a patient's risk for developing mucositis. Ultimately, chemotherapy appears to be the primary driver, and this is agent and regimen specific, with S-phase specific agents having the highest risk. The duration, dose intensity, and schedule can also increase the patient's risk, where prolonged or repetitive lower doses have higher risks than bolus doses. We also see the risk increase as the patient increases their number of chemotherapy cycles. Finally, the risk can be increased when clearance of chemotherapy is delayed due to renal or hepatic impairment. Radiation exposure can also increase the risk, but this is dependent upon the radiation source, dose intensity, and the volume of the mucosa that's irradiated. There are other risk factors that include the patient smoking and alcohol consumption, as well as having a dry mouth or concurrent infection. As I mentioned, the incidence can vary widely by the chemotherapy agent. However, the ones listed here are those most commonly implicated. These are grouped by their chemotherapy class and then further subgrouped based off of the subclass. So for example, under alkylating agents, you can see the platinums have been grouped together, followed by agents like cyclophosphamide and ifosfamide. Once a patient is determined to be at risk for the development of mucositis, what can be done to prevent it? Well, MASC has developed a series of guidelines that address prevention and treatment of both GI as well as oral mucositis. So first, looking at the prevention of GI mucositis, this includes radiation-induced esophagitis as well as proctitis. These patients typically have the small intestine affected more than other organs such as the esophagus or stomach, and symptoms can vary but include nausea, vomiting, and diarrhea. MASC guidelines recommend the specific use of amifostine prior to radiation to prevent radiation-induced proctitis. They also suggest that amifostine, oral sulfasalazine, and probiotics containing lactobacillus may be beneficial in specific situations. However, they strongly recommend against other agents such as 5-acetyl salicylic acid and rectal misoprostol in the indications listed here. Based off of conflicting data or a lack of evidence, they cite that they cannot make a specific guideline recommendation regarding the use of oral famotidine, fat-modified diets, or oral glutamine. For patients who develop GI mucositis, there's currently no strong data to support any specific therapies in this setting. However, guidelines suggest that sucralfate enemas and hyperbaric oxygen may be beneficial in specific settings. They also recommend against the use of oral sucralfate after radiation in patients with solid tumors. And again, they say that there's no consistent evidence to make strong recommendations for the therapies listed here. When focusing on the prevention of oral mucositis, the guidelines make 4 specific recommendations, including the use of palifermin, benzidamide hydrochloride mouthwash, low-level laser therapy, and oral cryotherapy in very specific settings. Patients with oral mucositis have primarily the non-keratinized mucosa on the soft palate, cheeks, lips, floor of the mouth, and ventral surfaces of the tongue that are affected. They can have erythema and ulcerations, and can also complain of other symptoms as well. The guidelines do suggest that other therapies may be beneficial, and there are a whole host of agents that they recommend strongly against. They also say that there's no guideline available for agents such as oral zinc, supersaturated calcium phosphate, celecoxib, oral glutamine, topical vitamin E mouthwashes, or oral selenium based off of conflicting data or a lack of strong evidence. And finally, for those patients who develop oral mucositis, the only treatment that's currently recommended is a PCA with morphine to treat mucositis pain in our stem cell transplant population. The guidelines do suggest that transdermal fentanyl, morphine mouthwashes, or doxepin mouthwashes may be helpful, but they recommend against sucralfate mouthwashes. And then again, they say that there's conflicting or not enough evidence to make a recommendation one way or another regarding supersaturated calcium phosphate, vitamin E mouthwashes, or topical vitamin E. Now that we've completed our review of GI complications, let's look at anticoagulation in the cancer population.
Cancer patients are at risk for VTE for a variety of reasons, including patient and treatment-related factors, as well as other modifiable risk factors. When looking at those factors associated most highly in cancer patients and their risk for VTE, we know that cancer type is highly important, with the highest incidence of symptomatic VTE occurring in those with ovarian, brain, and pancreatic cancers. A California registry evaluating all cancer patients found that the risks of DVT and PE occurred predominantly in patients with metastatic disease, and the relative risk of symptomatic VTE varied by cancer type in those with metastatic disease, being seen significantly higher in those with melanoma, bladder, breast, and uterine cancers. We also know that the patient's time from cancer diagnosis is important, with the greatest risk of VTE being seen within that first year. High-risk chemotherapy has also been discussed quite widely across the guidelines in terms of a risk factor for a cancer patient's risk of thromboembolism. And in the 2020 update, NCCN specifically mentions immunomodulatory drugs in combination with high-dose dexamethasone, as well as proteasome inhibitors carrying some of the greatest risk of VTE in our cancer population. Exogenous hormonal therapies, such as hormone replacement therapy, combined hormonal contraceptives, and tamoxifen also carry a known risk. Additional risk factors in this population may occur concomitantly, including hospitalization, infection, and other acute illness, decreased mobility, and advanced age.
While many risk factors for VTE have been identified, those patients at greatest risk of symptomatic VTE within the next 6 months can be more accurately predicted using a model such as the Khorana score. This score takes into account the patient's cancer site, their platelet, hemoglobin, and white blood cell count prior to chemotherapy, as well as their BMI. It should be assessed at baseline and then periodically, such as prior to starting each treatment or at the time of hospital admission. This is a risk assessment tool that's been validated in ambulatory patients with solid tumors that are being treated with systemic chemotherapy. However, it has been applied to hospitalized patients to predict the risk of VTE during the admission. Other tools have added risk factors such as D-dimer or the type of chemotherapy to the Khorana scale. However, most of these have not been validated.
In addition to the Khorana score, 2 other predictive models were added to the 2020 update of the NCCN guidelines to assess the risk of VTE in multiple myeloma patients receiving immunomodulatory drugs. These were the SAVED and the IMPEDE VTE scores. These scoring systems contain components similar to the ones used in the Khorana score, with the SAVED being the most simplistic. You can see for the SAVE score, the variables that are included are the use of dexamethasone, prior surgery, race, VTE history, as well as age. And then based off of this score, patients are stratified into low and high risk groups, with the recommended prophylaxis being aspirin in the low risk group, and then a variety of agents for the high risk group, including enoxaparin, dalteparin, warfarin, and potentially apixaban. The IMPEDE VTE score is more comprehensive than the SAVED score, but therefore may be less practical in a clinical setting. Similar to the SAVED score, it assesses risk of VTE in the multiple myeloma population, evaluating the use of dexamethasone, immunomodulatory therapy. It also takes into account race and prior VTE history. What makes it different than the SAVED score is its utilization of BMI, prior fractures, concurrent use of erythropoiesis-stimulating agents or doxorubicin, as well as an evaluation of therapeutic or prophylactic agents for anticoagulation, and then the presence of a tunneled line or central catheter. Similar to the SAVED score, patients are categorized into one of 2 groups. However, with the IMPEDE VTE score, the threshold is 3 points compared to the SAVED score that uses a threshold of 2 points. Recommended prophylaxis is similar, with low-risk patients receiving aspirin and then high-risk patients receiving either a low molecular weight heparin, warfarin, or potentially apixaban. When determining whether a cancer patient could benefit from VTE prophylaxis, it's important to consider the setting. For our ambulatory patients, ASCO generally does not recommend VTE prophylaxis. However, they do state that apixaban, rivaroxaban, or a low molecular weight heparin may be offered to those with a Khorana score of 2 or higher prior to chemotherapy, and in the absence of any significant drug-drug interactions or major risk factors for bleeding. NCCN more strongly words their recommendation in favor of VTE prophylaxis, specifically for those with a Khorana score above 2. They also state that in patients with multiple myeloma, they should be assessed instead using either the SAVED or IMPEDE VTE scores. Ultimately, if primary prophylaxis is pursued, a discussion should occur with the patient that weighs the risks and benefits, as well as the costs, and a discussion of the potential duration of treatment. For hospitalized patients, ASCO recommends pharmacologic prophylaxis in those with active malignancy for the length of stay or until they're ambulatory in those with medical illness or decreased mobility. It also may be offered to those with active malignancy even in the absence of other risk factors, but should not be offered to those admitted just for chemotherapy or a minor procedure. NCCN is more universal in their recommendations, saying that all hospitalized cancer patients should receive pharmacologic prophylaxis in the absence of a contraindication. While a recent meta-analysis did not show a benefit in pharmacologic prophylaxis for hospitalized cancer patients, this was a small subgroup of the analysis, and it was a more heterogeneous cancer population. Based off of our large body of literature to date, pharmacologic prophylaxis continues to be recommended in most hospitalized cancer patients, but the recommendation is more controversial in those without additional VTE risk factors, and physicians may be hesitant to initiate VTE prophylaxis in this population due to a perceived risk of bleeding. Regardless of the setting, the decision to use anticoagulation at both therapeutic and prophylactic doses should take into account any relative or absolute contraindications, with the absolute contraindications being self-explanatory, including things like active major bleeding or an uncompensated coagulopathy, severe platelet disorders or bleeding disorders, thrombocytopenia, hemorrhagic CNS disease, or indwelling neuraxial catheters or procedures. The relative contraindications may be considered absolute contraindications, particularly in patients where we're considering the use of DOACs. In these populations, low molecular weight heparins will be preferred over DOACs for treatment specifically. And based off of the limited safety data for our DOACs, we should consider many of these relative contraindications to be absolute in the setting of DOAC use. Our relative contraindications for anticoagulation include active GI bleeding or other active bleeding, recent high-risk surgeries that would put the patient at risk for bleeding complications, persistent thrombocytopenia at a platelet count less than about 30 to 50,000, and those patients who are at a high fall risk with CNS disease or on antiplatelet therapy. It's important to note that the updated NCCN guidelines do pull out some specific contraindications for prophylaxis specifically, and these include active bleeding, thrombocytopenia to a platelet count less than 30 to 50,000 or clinical judgment, a hemorrhagic coagulopathy, indwelling neuraxial catheters, upcoming lumbar puncture, or other interventional spine or pain procedures.
The potential agents that may be considered and their doses are listed here for your reference, with several caveats that should be considered for each agent. Now that we've discussed which patients are at the greatest risk for VTE and have evaluated patients for exclusion from anticoagulation based off of contraindications, let's look at the data regarding the use of DOACs specifically for primary prophylaxis in the oncology population, starting with the AVERT trial. This was a study of 563 patients. It was a phase 3 randomized double-blind placebo-controlled trial of ambulatory patients with newly diagnosed malignancy or progression preparing to start a new chemotherapy regimen. They had to have a Corona score of at least 2, and they were randomized to apixaban versus placebo for a minimum of 3 months. The primary endpoint was VTE that was objectively documented during the 180-day period. The investigators of the AVERT study found that the rate of objectively documented VTE in the apixaban arm was 4.2% compared to 10.2% in the placebo group, which was statistically significant. However, also statistically significant was the rate of major bleeding at 3.5% in the apixaban arm compared to 1.8% in the placebo group. The Cassini study was a larger study of 841 patients. It was also a phase 3 randomized double-blind placebo-controlled trial in ambulatory patients with both solid tumors as well as lymphoma that were starting new chemotherapy regimens with a Corona score of 2 or higher. What differs the Cassini trial from the AVERT study in terms of patient population is that these patients had to have a documented absence of VTE at baseline. This was not evaluated in the AVERT study. The Cassini trial randomized patients to rivaroxaban or placebo for 180 days, and they utilized a composite endpoint that included objectively confirmed lower extremity proximal DVT, PE, symptomatic upper extremity or distal lower extremity DVT or VTE-related death. While they did not find a difference in the efficacy of the primary endpoint between rivaroxaban and placebo, these results were numerically different with a lower rate of composite endpoint in the rivaroxaban arm. However, there was also no difference in the rates of major bleeding in this study, showing that rivaroxaban may be a safe alternative.
In terms of VTE treatment in the oncology population, there are 4 major studies to date comparing warfarin or DOACs to the low molecular weight heparin dalteparin. The first was the CLOT trial. This was a randomized open-label study of 672 patients with active malignancy and an acute symptomatic proximal DVT or PE. Patients were randomized to dalteparin or dalteparin bridged to warfarin treated to an INR goal of 2 to 3, and their primary endpoint was symptomatic recurrent VTE within the 6-month study period. The investigators found that 8% of patients treated with dalteparin experienced a symptomatic recurrent VTE as compared to 15.8% treated with dalteparin bridged to warfarin, and this was statistically significant, favoring the dalteparin arm. The rates of major bleeding were higher in the dalteparin group, however, this was not found to be statistically significant. The next 3 studies I'm going to discuss look specifically at various DOACs compared to dalteparin. The first is the Hokusai VTE cancer trial. This is an open-label non-inferiority study of over 1,000 patients with active malignancy and acute symptomatic or incidental VTE. Patients received either edoxapan or dalteparin for a minimum of 6 months, and their primary endpoint was unique in that it was a composite endpoint of recurrent VTE and or major bleeding. This primary endpoint found that edoxaban was non-inferior to dalteparin. However, the rates of major bleeding were statistically significantly higher in the edoxaban arm, with a rate of 6.9% as compared to 4% with dalteparin. And what I'd like you to keep in mind as we talk about the next 2 studies is that the rates of major bleeding in the dalteparin arm were consistent amongst all of the DOAC studies at 4%. Our next trial is the SELECT-D study. This was a randomized open-label controlled trial of just over 400 patients with active solid or hematologic malignancies, an acute symptomatic DVT or PE, or an incidental PE. Patients were randomized to rivaroxaban or dalteparin with a primary endpoint of recurrent VTE during the 6-month study period. The investigators of this trial found that 4% of patients treated with rivaroxaban experienced a recurrent VTE, as compared to 11% in the dalteparin arm. Rates of major bleeding were approximately 6% in the rivaroxaban group, and again 4% in the dalteparin group, and this was not statistically significant. Finally, our most recent study that was published in the New England Journal of Medicine in 2020 was the Caravaggio trial. This was a randomized, open-label, controlled, non-inferiority trial of just over 1,100 patients with active malignancy and acute symptomatic or incidental proximal lower limb DVT or PE. Patients were randomized to apixaban or dalteparin with a primary endpoint similar to the SELECT-D trial of a recurrent VTE within the 6 months. This study found that 5.6% of patients receiving apixaban experienced a recurrent VTE, compared to 7.9% in the dalteparin arm. Rates of major bleeding again were 4% with dalteparin, and lower than what we had historically seen with our DOAC studies of 3.8% with apixaban, but this was found to be not statistically significant. One thing to keep in mind when evaluating all of these trials is that they all had widely varying inclusion and exclusion criteria, including what they allowed in terms of performance status, renal and hepatic function, as well as disease state characteristics and platelet thresholds. So it's important to evaluate each of these parameters very carefully when selecting which DOAC might be most appropriate for the treatment of VTE in the cancer patient.
The rates of major bleeding are acknowledged in each of these studies, and a discussion of reversal is warranted, although the details of which are beyond the scope of this presentation. So importantly, NCCN does provide more detail regarding anticoagulation reversal, and the key points are highlighted here in this table. Also, because these patients often undergo surgical procedures, one should be familiar with the peri-procedural recommendations. This includes an assessment of baseline clotting risk, thrombotic risk category, and procedure-specific management based off of the bleeding and clotting risk profiles. These can all be found in the NCCN guidelines as well. Finally, we need to address the supportive care aspects for our patients that include pain management and palliative services for symptom management. Palliative care is defined as patient and family-centered care that optimizes quality of life by anticipating, preventing, and treating suffering. Palliative care services should address the physical, intellectual, emotional, social, and spiritual needs of the patient, and should also facilitate patient autonomy, access to information, and choice. The majority of data for palliative care services is available in a white patient population at tertiary care centers in high-income countries. So many of these recommendations may be difficult to extrapolate to centers with fewer resources. Ultimately, the components of palliative care should include assisting in building relationships between the patient and the caregiver, managing a patient's symptoms, determining the patient's understanding about their illness and prognosis, helping the patient clarify their goals of treatment, assessing and meeting the needs of the patient to allow for optimal coping, assisting with medical decision-making, and helping to coordinate care. Ultimately, these palliative care teams should be interdisciplinary. The benefits of early palliative care are very clear, and it's been clearly documented that there can be an improvement in 1-year overall survival, the patient's quality of life, the patient's satisfaction, symptom intensity, and an increase in the referrals for adjunct services, with a decrease in the patient's depressed mood, a decrease in the use of chemotherapy within 60 days of death, and a decrease in aggressive care at the end of life.
There are several patient populations that should be screened for or have an indication for palliative intervention, as the presence of these factors suggests a worsening prognosis. These indications include the presence of life-limiting disease or a poor performance status, symptoms or evidence of disease progression, including persistent hypercalcemia, brain mets, delirium, bowel obstruction, or spinal cord compression, and then the necessary required procedures like palliative stenting.
But ultimately, who should be offered these palliative services? Current guidelines recommend that patients with newly diagnosed advanced cancers, where advanced cancer is defined as the presence of distant metastasis, late-stage malignancy, disease that is life-limiting, or a prognosis of 6 to 24 months, in these patients, regardless of being in the inpatient or outpatient setting, they should have palliative care involved within 8 weeks of diagnosis. Additionally, patients with uncontrolled symptoms or those who have moderate or severe distress due to a cancer diagnosis or their cancer treatment should be involved with palliative care. Other patients that should be considered are those with significant physical or psychological comorbidities, patients who have complex psychosocial needs, those with poor awareness of their prognosis, patients with a disease that's potentially life-limiting, metastatic solid tumors, those with concerns about their disease course or decision-making, or in patients who specifically request to have death hastened should all be plugged in with our palliative care team. Offering palliative services does not preclude the use of active treatment, and that should be emphasized with patients, particularly those who are hesitant to seek out palliative care services. But ultimately, we should remember that palliative services should be offered to all patients at the time of diagnosis with an advanced malignancy, and this is regardless of setting. The question of patients receiving active treatment or addressing anti-cancer therapy in the palliative setting is often asked. And so to help patients determine what's the most appropriate for them, it's important to consider the following based off of the patient's life expectancy. So for patients with a life expectancy of months to years, you'll want to begin assessing their understanding of their prognosis and address goals of care. There are other things that can be addressed at this time as well, such as helping the patient prepare for the possibility of disease progression or recurrence. Patients with a life expectancy in the range of weeks to months, we should be confirming their understanding that this malignancy is no longer curable and redirecting their goals based off of this prognosis. Guidance can also be provided based off of the course of the disease, and other therapies can be offered at this time. Those with a much shorter prognosis, including a life expectancy of days to weeks, at this point in time, we should begin stopping treatments that are not contributing to the patient's comfort and begin providing guidance on the dying process with a focus on symptom management and comfort. Pain management is commonly encountered in patients in the palliative setting, and it can become difficult to balance analgesia with altered consciousness, and this should be done based off of the patient's preference. Agents such as opioids, acetaminophen, NSAIDs, and other adjunctive therapies should be offered in this setting. For your reference, I've included a table here that helps with opioid conversion between agents as well as between IV and oral dosage forms. For patients with acute severe pain, which the guidelines define as a pain score of 8 or higher, require hospital admission. There are different considerations in terms of management for patients who are opioid naive versus those who are opioid tolerant. Opioid naive would be those patients that are not currently receiving daily opioids, and there are specific definitions for those that would be considered opioid tolerant. You can see that for patients who are opioid naive, the initial agent should be morphine or a morphine equivalent at the doses listed here based off of the choice of IV or PO dosage forms. For patients who are opioid tolerant, the general recommendation is to increase the total dosage by 10 to 20% based off of what the patients received in the last 24 hours. Patients should then be subsequently monitored for response and adverse effects within 60 minutes, and ultimately recommendations can be made based off of their response. Another common symptom in the palliative setting is dyspnea. Patients should be treated for potentially reversible causes with radiation, chemotherapy, or other procedures such as a thoracentesis. Bronchodilators, diuretics, steroids, antibiotics, and transfusions may be considered when indicated, and anticoagulants can be used if PE is the cause of the dyspnea. Other symptom management can include oxygen for hypoxia, opioids such as morphine listed here in the table, benzodiazepines if there's an anxiolytic component, and then diuretics for volume overload. Non-pharmacologic therapies may be implemented, such as fans, cooling the room temperature, stress management and relaxation therapy, as well as offering physical comfort. Patients with excess secretions are managed slightly differently with the agents listed here, with a focus on scopolamine, atropine, and glycopyrrolate. Patients in the palliative setting also often experience anorexia and cachexia, with anorexia being defined as a loss of desire to eat, as compared to cachexia, which is defined as the physical wasting with a loss of skeletal and visceral muscle mass. It's important to assess conditions that may interfere with PO intake, like dry mouth, mucositis, candidiasis, depression, and fatigue. Depending on the patient's life expectancy, the guidelines recommend a variety of options. Ultimately, we should also assess for a decrease in dose or a change in medications that might be interfering with the patient's intake. Other considerations would be nutritional support, appetite stimulants such as mirtazapine, and caregivers should be educated that the absence of hunger and thirst does occur in a dying patient. Also, that nutritional support may not reverse the weight loss, and that there are risks associated with offering artificial nutrition. Ultimately, it should be reinforced to caregivers as well that it is considered ethical to withhold or withdraw nutrition, as that can often improve the patient's symptoms. Up to 45% of hospice patients complain of constipation, and this can be related to their primary disease, the therapy that they're receiving, other medications, neurologic conditions, metabolic comorbidities, or gastrointestinal causes. Prevention should be implemented when indicated by increasing fluid and fiber intake, utilization of a stimulant or osmotic laxative with a goal of 1 non-forced bowel movement every 1 to 2 days, and we should also be discontinuing any medications that are not essential that may be contributing to constipation. General constipation can be managed with bisacodyl, again with the same goal of one non-forced bowel movement every 1 to 2 days, and other stimulant or osmotic laxatives can be added. For patients with impaction, glycerin suppositories with or without mineral oil retention enemas can be used, but if persistent constipation persists despite these stimulant and osmotic laxatives, additional laxatives can be added, giving consideration to things like Miralax or polyethylene glycol, lactulose, sorbitol, magnesium hydroxide, or magnesium citrate. In patients with opioid-induced constipation, agents such as methyl naltrexone should be considered.
For those with malignant bowel obstruction, management may depend on whether or not gut function can be maintained. NCCN recently removed that caveat from their drug therapy recommendations, however still allude to this concept in other areas of their text. Prognosis also plays a role in the management of these patients. For those with a prognosis of months to years, you'd want to assess for reversible causes such as adhesions, radiation-induced strictures or hernias, as well as cancer-related causes such as carcinomatosis. You may also consider TPN in this patient population if you expect improvement in their quality of life. In those patients with a prognosis of days to months, it's primarily medical management and the potential use of IV fluids. Now, historically, when you'd want to maintain gut function, you'd decrease opioid dosage or rotate your opioids or utilize medications such as metoclopramide or dexamethasone, with a focus then on your anti-secretory agents when function cannot be maintained. However, the most recent version of the NCCN guidelines lists all of these as options regardless of the goal of maintaining gut function or not. Many of our cancer patients struggle with symptoms of fatigue, weakness, and insomnia. Historically, we have not had any guidelines for the treatment of fatigue. However, some have been recently released, but were not included in this update. Various stimulants may be tried for fatigue, and our prior NCCN guidelines on palliative care give no preference to one particular agent over another. For the management of insomnia, there are several factors that should be assessed prior to initiating therapy. The first would be to evaluate daytime impairment, as well as assess the patient for fear and anxiety related to their prognosis and the process of dying. They should also be educated on sleep hygiene, as well as stimulus control and the process of progressive muscle relaxation. Finally, if there are any underlying factors, such as pain, delirium, or nausea, those should be treated, and the patient should be assessed for side effects due to medication, such as corticosteroids or caffeine. In those patients with a life expectancy of weeks to years, a variety of agents may be tried for the treatment of their insomnia, including trazodone, an atypical antipsychotic like quetiapine, mirtazapine, a benzodiazepine such as lorazepam, or more traditional agents like zolpidem or ramelteon. In those patients with a life expectancy of days to weeks, you can take their current therapy and titrate the dose more rapidly than you may otherwise do.
Patients in the palliative setting may also experience one of two types of delirium, including hyperactive delirium defined by agitation, restlessness, and aggressiveness, as well as hypoactive delirium described with motor retardation, apathy, and patients who appear more sedated. Again, assessing for reversible causes such as metabolic causes can be important, and delirium is ultimately managed based off of the severity of symptoms. For mild to moderate delirium, agents such as haloperidol and atypical antipsychotics can be used, where titrating to the lowest effective dose while minimizing adverse events is going to be important. Also, it's important at this time to begin to reorient the patient with their family and caregivers. For those with severe delirium or agitation, haloperidol and olanzapine have been shown to be the most effective. So while we've covered a wide variety of supportive care topics, there's a few key points to take away. Ultimately, the prevention of chemotherapy-induced nausea and vomiting is essential. And while current guidelines are not always consistent with which agents and doses should be used, there is some overlap based off of regimen and metagenicity. Chemotherapy-induced diarrhea is increasingly more common and should be treated according to the severity of symptoms, whether uncomplicated or complicated. There is limited or inconsistent evidence for formal recommendations in the prevention and treatment of GI and oral mucositis, and this is with the exception of amifostine and palifermin, which are recommended in very specific settings. More recent evidence has begun to support the use of our DOACs for the prevention and treatment of VTE in patients with cancer. And as we just discussed, palliative services should be offered to all patients at the time of an advanced malignancy diagnosis. So thank you so much for listening today as we discussed these various supportive care topics, and I appreciate your participation.